Ladies and gentlemen, it gives me the greatest pleasure to welcome you all to Respire 2024, the annual academic sessions organized by the Sri Lanka College of Pulmonologists. We have an interesting lineup of up to 6 different symposiums for the day. We kindly request you all to keep your phones on silent mode at all times and enjoy today's proceedings. And with that, we have our first guest lecture on new therapies in interstitial lung disease and symptom-based management. I now cordially invite the chairs, Dr. Bodhika Samarasekara, the President of the Sri Lanka College of Pulmonologists, and Professor Dushantha Madigadara, the Academic Chair of the Sri Lanka College of Pulmonologists, to introduce the speaker.
Good morning, ladies and gentlemen. The first guest lecture is done by world-renowned professor, Professor Atal Wells, who has done a lot to ILD and management. And he's the professor of respiratory medicine in Royal Brompton Hospital and Imperial College London. Over to you, sir.
First of all, check whether you can hear me in the back. You can. That's probably a shame. And therefore, let me make a start. So I have to confess to one piece of embarrassment. On loading my talk just now, something truly weird had happened to the font. So you're going to find there's a section of the talk where I must speak without slides because I went through and removed some really weird slides. So you're going to be able to have a nice rest. You're going to have quite a bit of data. Then I'm going to have to just speak without slides, and then we'll come back to data. So there will be a pleasing symmetry about the talk. So let's make a start. And I'm going to focus, the title was New Therapies, and by that I take it therapies we can use, therapies that are approved. I'm going to say a little something about precision medicine and its principles, and that's where I'm afraid you lose some slides. So the therapies that are newer, that we can use, are more in connective tissue disease than they are in IPF, and I'm going to cover that to start with. Then I will touch on new therapies and precision medicine in IPF, and then I'm going to make some comments about symptomatic support, stressing that there is really nothing that is major and new regarding symptomatic support, but it's going to be worth us going over this systematically. So let's now think about new regimens and also interesting treatment signal, adapting some of our therapies to new indications. And I'm going to begin with systemic sclerosis with a case, a real case. And this was a 27-year-old woman. It's important to stress when you see the scan that she was a lifelong non-smoker, known to have ILD for over the 2 years at which we think it progresses most strongly, but she'd only had a year of exertional dyspnea. And in spite of the gas transfer, you can see, she was still unlimited on the flat, managing a flight of stairs. She'd had mycophenolate throughout the 3 years. She'd also had iloprost for skin ulcers. We think this gives us a free access sometimes to the pulmonary vasculature. And the other therapies that you see. Now, I don't know how clearly this comes up on the screen. I will just guide you through a little, and hopefully what you can see is what looks like something I can't show with this pointer. It seems to have a flat battery. Let me just see if I can show it here. Yes, I can. That's good. And you can see what looks like emphysema rather than interstitial lung disease. And this happens in a subset of patients with systemic sclerosis. So you will get emphysematoid destruction following areas of ground glass in those regions in about 5% of scleroderma lung patients that are lifelong non-smokers, and emphysematoid ILD. And over the 2-year period, there had been the declines that you see in lung function from the baseline lung function I showed you, with the DLCO now down to 25%, and no evidence. Sorry, thank you. That's good. Thank you very much. No evidence of pulmonary hypertension. Now, what can we think about with management? Because until recently, we've had very few options in this setting. I mean, a lot of mycophenolate for 3 years, it's failed. You can see progression in spite of mycophenolate. We tended in the past to give intravenous cyclophosphamide because really we had nothing else we could give. And occasionally we believed, and that's the trouble with anecdotal medicine, you can't trust it, but we believed sometimes that cyclophosphamide did do something that mycophenolate wasn't achieving. And then we've got to think about lung transplantation. Now, in a spirit of talking to things you're allowed to use, at least in some countries, not yet approved in others, we now have more to say with recent treatment effects, and this is summarized in a clinical practice guideline. I will be honest with you, I can't stand presenting guidelines. You're supposed to talk about grade and conditional positives and strong positives, and it's boring. But I think you can show a summary slide as a framework for what you might use. So what is actually recommended now? Tocilizumab, rituximab, and nintedanib. And these are our possibilities in what you can use, and how are you going to adapt this now for this patient? Which of these drugs are you going to use? Are you going to use just one? Are you going to use two? Young woman, gas transfer 25%, it was 46% 2 years ago, and this is an unusual version of scleroderma lung. Well, just a brief word, it's an older treatment than the rituximab trial. And this is tocilizumab, randomized, double-blind, placebo-controlled phase 3 trial. Now, importantly, these were patients who had early scleroderma. And remember, this patient is 3 years of at least systemic sclerosis. And remember that the strong sense with rituximab is that it is a very much better drug when there's diffuse skin involvement. Indeed, this trial was a trial of diffuse skin involvement where FVC was included as a secondary endpoint, but seemed to have a striking effect. But you are probably catching that explosive early stage of connective tissue disease when lung function fall is at its most rapid. So of the three options, for scleroderma of this type, I think I put a cross against that. Now we have rituximab. And yes, this is being used a good deal internationally. I think you have to be candid about the fact that the main trial, there are 3 trials you can take seriously, but the main trial, in point of fact, is not so very impressive. So it's, again, one of these trials where skin disease was the primary endpoint and lung was used, FVC, as a secondary endpoint. Really, the investigators were going for where they thought the money was, but they were having one on the side by looking at lung function also. And so the requirement, again, was a certain skin thickness score, and the rituximab regimen that you see. Now, I don't know if you can see this on the slide, but if you ignore for the moment the skin score, which was positive, you get this effect with an absolute change with a difference of 3% of predicted in 24 weeks, but it is matched by an effect on high-resolution CT. So it's significant, but it's one of these classic observations we see a great deal. On average, significant, on average, small, but contained within that will be some patients who benefit a lot, who contribute and make up what is an average effect. So can you get at this, or are you going to reserve this for patients that need it? Now, until a trial that was published last year, I would not have used rituximab in this patient. But then you come to combination therapy between mycophenolate and rituximab, the EVER-ILD study. And this really compares rituximab versus placebo on a background of mycophenolate. And so you've got mycophenolate as maintenance therapy, and when you add rituximab to that, and this was what we would be doing with this patient, you can see here that the average benefits are really reasonably impressive. So this is a case where I would look at combination therapy. And I'm going backwards, which is never a good idea, even though I did want you to take aboard those slides. And now we'll come to how should we use antifibrotic therapy here. So I'm saying that I think we would add rituximab to mycophenolate in this patient. Clearly, I can't prove to you that it is going to work, but we've got to do something because things are moving rapidly and badly, and we want to bridge her to transplantation. So buying some time is crucial. So what about nintedanib? And I do want to say a bit about this, and yes, the nintedanib trial, it said new treatments, and this is 5 years old. But what is not 5 years old is some of the subgroup analyses when we think about who might benefit from nintedanib. And they've taken a while to come out, the subgroup analyses, but they really are worth considering. So if we think about the trial itself, the census study, you did not have to have progression in spite of management to be enrolled in the trial. So it's the one non-IPF trial where you actually get into the trial at baseline. And that's important when we apply this because regulators have approved census and it doesn't require you to observe the patient and see progression. But in this case, this is what has happened. Second point, on average, the benefit is 41 mils in FVC per year. So the treatment impact is just 41 mils, and that's because scleroderma lung in the trial cohort did not progress at the same rate in placebo as does IPF and some of the other fibrotic ILDs. So you really are talking about only just under 100 mils in the placebo arm and a gain of 41 mils. So you're preventing about 45% of progression. That sounds impressive. I can see why what was considered something of an orphan disease in younger patients went through FDA very quickly, but the overall benefit a great deal less in its amplitude than the use of nintedanib in other settings. And I think you can then break down, and this is a 2023 study, you can look at subgroups of this cohort and see who benefits. And again, let me see if you can see, but this is all subjects, and just take note of the gap and take note of the amplitude of placebo. You don't have to read the numbers. I'll take you through this. And then, as you see, if you've got less than 18 months of disease, you're progressing an awful lot more with a much greater impact in the treated arm, elevated inflammatory markers, a thicker skin score. There are two thresholds here. So instead of losing 90 mils, you're losing 130 odd mils in that set. And in a smaller group with very recent disease, you're losing 160 mils a year. So immediately you have a sense, you have clues into who you should think more seriously about using this drug in. Now, what we can also work out from these data is if you take just one risk factor, you can calculate, since you know the average overall benefit, you know the numbers, you know the benefit in the most prominent risk factor, you can work out the benefit in the remaining patients. And so what I've chosen here is the modified skin score of more than 18. And this is all subjects, and this is the exactly quantified number of patients with this risk factor. So if you don't have skin thickness, you can work out that in the remaining patients, you are spending $30,000 a year to save 27 mils in FVC on average, which I suggest is not entirely cost effective in a disease that often stabilizes with time. So we can have, I think, a very helpful clue as to who should receive nintedanib at baseline. I believe if disease is severe, it's not captured in the analyses, but you have a track record of having progressed repeatedly in scleroderma in a disease in which progression can often switch off. So you're in that subgroup that's likely to go on progressing, and in our patient that I've shown you, I unhesitatingly supported the use of nintedanib. But I think other than that, you need a risk factor. You either have to have a lot of skin thickness, I suggest, or else you've got to have relatively recent onset, a bit like the population in which tocilizumab was trialed. So I think in summary of this section, we are talking about this benefit with census. This is just lung function analyses, again showing that if you've got more severe disease in the placebo arm, you progress more, whether it's FVC or a DLCO of less than 50. So if the DLCO is more than 50, you lose 65 mils a year. It's double that if the DLCO is less than 50%. So that's what I say about applying therapies in a new way, based on what's approved last year in a guideline, what is available, what can be used and accessed. And in this case, rituximab, nintedanib, refer for transplant. Now let's go to rheumatoid lung, and I really want to just mention two therapies. One of them you may be able to access, but it hasn't been properly trialed, which I think is an amazing thing when you look at the wealth of observational data. The other one is a drug we're not yet allowed to use outside IPF, according to the guideline. It's pirfenidone used in rheumatoid lung, and I want to take you over both sets of data because I think you can consider accessing pirfenidone as a generic, and I understand you can do that in this country. And abatacept is a very interesting drug. I don't know how many of you have really thought about this drug in rheumatoid lung, and to remind you that rheumatoid lung is potentially our most devastating connective tissue disease, ILD. So this drug attaches to T cells, blocks intracellular communication, and this is a prospective cohort study which basically confirms essentially what are a series of meta-analyses. Now, basically in observational studies, you go to Mexican study, Italian literature, Spanish literature, and what you see in every single study, and some of them are powered, is that the use of this drug, abatacept, seems to be associated with stabilization on average, whether you have a UIP pattern in rheumatoid lung or an NSIP pattern. And on average, in a recent meta-analysis, it's 55 to 45, the ratio of UIP to NSIP. And UIP in rheumatoid, for other managements, has behaved broadly like IPF. Now, when you've got retrospective observational studies, each and every one of them is flawed, but the flaws are different from study to study, so it can be useful to group them together. And when you do that, you get the following information. Now, you're used to these plots, and basically, when you see FVC and these plots and DLCO, you think you're looking at a drug that doesn't work. But actually what's done here is there a difference between the start of the use of abatacept and the end of the treatment period? And what you see is there isn't. There is definitive stability across cohorts, some of which are reasonably powered. You see well over 100 over, in total, 200. And both DLCO and FVC are stable. Now, the authors did parallel analyses, and this drug, in these analyses, did quite a bit better than rituximab. But I suppose because it hasn't been commercially powered enough, no formal trial is being launched. If you're desperate in rheumatoid UIP, this seems to me a way that you can choose to go. And this is, I think, the observational study I referred to, which is a follow-on from this, and it's a recent study, only online when I tried to actually put in more detailed references. 190 patients, 106 with UIP. They should be behaving like IPF on average, and also 84 with NSIP. But actually, and you never seem to see this outside this setting, CT improved or stabilized in 3/4 in UIP and in 90% with NSIP, and breathlessness improved or stabilized in 3/4. Now I come to pirfenidone, and this is the last of the new therapies which you can use in practice, and this is a very interesting trial, I think, with the use of pirfenidone in rheumatoid lung. Now, this is officially a negative study, and the reason that it's a negative study is there was a really weird, difficult to justify primary endpoint. And I do think COVID, breaking the study short, did not help. So the study was underpowered. But it was one of these studies where you either had to die or reach a 10% of predicted change in FVC, with the result that in both arms there was a tiny amount of events. You could not see a statistical difference. So what did you see if you actually used what you ought to use, and that is FVC change as a continuous variable? And this is what you see here. Pirfenidone versus placebo. This is FVC change analyzed in two different ways. And what you can see is that clearly, with decline in FVC in mils, whether you're talking about the whole population or that subgroup with a UIP pattern, and each time that is stronger, are striking benefits. And overall, there was a UIP pattern in about 2/3 of patients with an irritating imbalance between arms, but that's unexplained. I think it's chance, but you take that into account. And then let's look at those patients who have UIP and rheumatoid, these two, and the remaining a third of patients that don't. So if you have UIP, 95% of progression is prevented. If you don't have UIP, your progression on average is slightly greater if you have what is likely to be NSIP, slightly greater with pirfenidone than without it. So that tells me that we need to subgroup in non-IPF ILD, that UIP should be viewed as a separate entity. And if you do that, it seems to me that pirfenidone looks like excellent treatment on what we have thus far in rheumatoid UIP. Now I'm going to touch on one sarcoidosis drug very quickly because it is the drug that's gone through phase 2. You can't use it yet, but if you're going to pick a sarcoid therapy that maybe you will be able to use in the near future, it is this drug. And it is one of those drugs that acts in a protein way on the immune system. It really switches down both innate and acquired immunity. And all I'm going to say is in the phase 2 trial, taking aboard that the slides don't really project in a large enough scope for you to see them, I will save you your eyesight. And I'm going to say it in words instead. There are 3 separate benefits in phase 2. There are positive FVC trends, and in spite of the fact that you've got more ability to reduce steroid, you get positive FVC trends. What I think is really impressive, though, is an unequivocal effect on quality of life due to major change in fatigue. Now, tomorrow I'm going to take you over practical management of sarcoid. To me, fatigue, what's the opposite of a red flag? I suppose it's a blue flag. If you're looking at a drug in sarcoid that you're really quite excited about, it's a drug that has parallel benefits on a major organ involvement and fatigue. And this is the profile of this drug. So this is the phase 3 study that's underway, targeted over 250 participants, 48 weeks. It's a monthly infusion, and indeed the endpoint is steroid tapering, because that is the single most desirable goal once you have patients treated with steroids, as well as FVC and fatigue. Now, I was going to say less about CTD and more about IPF till I discovered my slides have mysteriously disarrayed, so I'm forced to be very quick on IPF. It may be no bad thing, because you can't use the PDF inhibitor yet. You can't use pavrevolumab, but I'm going to say something about precision medicine. So this is the great desideratum you'll hear about. Firstly, the drug discovery model in IPF has tried to use precision medicine for decades, and we have not had a single therapy that's come out of that. The 2 drugs that work are what we might call dirty drugs. They're acting on a multiplicity of pathways, so sure, if you look at an animal or in vitro, you will find they do affect whatever mediator you're looking at, but they're not specific, they're not targeted, pirfenidone and nintedanib. And our problem is in IPF, if I showed you a slide of potential pathways and mediators, I'd need a screen as big as the combined screens for the sheer amount of pathway signal that exists in IPF. We have this meshwork of candidate pathways. Some pathways are upregulators because others are downregulated and vice versa. And we don't know if there are multiple IPFs, each with a precision pathway, or whether there's a primary pathway. And all we can say is various ways in which TGF-beta can be upregulated seem to be important, but there are a whole lot of pathways that do this. However, I am going to refer, if my slides will permit, to a trial which I think is very interesting. I had to weed some of these slides out because of the weird change in font. So this really takes us back to Panther. You all know Panther. And you'll remember that Panther was a disastrous outcome with historical treatments. But the trial that followed was antioxidant monotherapy versus placebo. And I'm sorry I can't show you the picture because it transmuted. But this was the very paradigm of a negative trial when you looked at FVC. And I really like to show this because the investigators were convinced that there was a subgroup effect. They were convinced because they had 2 phases of enrollment with changes in the nature of patients enrolled and different trends. So they looked very hard and they examined TOLIP mechanisms. And really they were looking at SNPs within TOLIP. And what I'm going to show, no, I can't. I had to weed this out. But what they saw was quite simple. With one TOLIP pathway, antioxidant therapy had major benefits on survival. In the other TOLIP pathway, so it was CC and TT, it was the reverse. Antioxidant therapy was highly deleterious. And in the heterozygote picture CT, it was neutral. And this was confirmed in a replication cohort. Now, I tell you what I'm referring to this. Here we have what seems to be a definitive negative study. Absolutely identical effects across a population. You find the key marker, and suddenly you're divided into major benefit and a major deleterious effect. And now you think about all the trials in IPF with marginal endpoints that are negative. We have probably missed the boat here with selective treatment effects. And we see that with the pavrevolumab trial. I was going to show that. The first trial was positive, the second has just come out, and it's negative. So you won't be using pavrevolumab, and it's out of my talk for that reason. That was incredibly encouraging, the first trial. My question is, was the first trial by chance getting a larger proportion of patients that were responsive? The PD-5 inhibitor, underpowered, weird placebo arms that were losing 500 mils a year of FVC in a 12-week trial. I can't advocate that we will see that. If the trial is replicated, it will be a magic therapy. We can't say a thing about this till we've got the next trial, but it should be with us very shortly. I should say something briefly about pulmonary hypertension. It's off point. So we're now dealing with a complication of ILD. And until recently, the pulmonary hypertension drugs in ILD had either been negative or damaging, or they'd shown in small cohorts some effects that might be beneficial but weren't compelling. So we were really doing very badly. I've got to refer to treprostinil for 2 studies, very, very briefly, till I close with symptomatic management. The first trial, effectively looking at pH markers in pH and showing quite a striking benefit on the 6-minute walk distance supported by secondary endpoints. The second trial post hoc showing quite impressive benefits on serial FVC. They're both of them question marks, especially the FVC trial. We may be looking, however, at, again, a subgroup effect, those patients who have vascular pathways in driving IPF and other fibrotic ILDs. We may see the second study as negative because by chance there are less patients enrolled with that pathway. So I come back in IPF to our problem with the assumption that a drug will act on all IPF patients. That is what the pharma model wants to actually win the market. but actually we are probably missing opportunities. Now, symptomatic management, and I believe we started a little late, but I'm going to try to keep to time. I think I've got about another 3 or 4 or 5 minutes, so let me speed for the last part of this. First of all, rehab. And I just want to make 4 points. You had, I think, a major session on rehab in general. You can look at IPF, for example, and this is a recent overview of systematic reviews. We've actually got to a stage that we don't just have systematic reviews, we have reviews of systematic reviews. And this is very recently published, which showing the major trial and their impacts in IPF of rehab. And there was nothing that was uncertain, and there was nothing that was harmful, but we're divided between maybe effective and support for strongly affected. The size of the circles is the size of the cohorts. So we're getting an average benefit, but this leads me to these issues. We've got problems with endpoints, and there's some discrepancy here. In some trials, exercise tolerance improves with rehab, in others it doesn't, but in the same trials it will work the other way around. Dyspnea scores don't improve, and in the other trial they do. Then there's quality of life. So how do you decide? And again, I think this is subgroup. Some patients with rehab will do the same amount of exercise with less dyspnea. Other patients will use the benefits of rehab to do more till they get to the same level of dyspnea. So you've immediately got a problem in trial cohorts. And I've long advocated a personalized endpoint in rehab trials. Now, what do I mean by that? It's been used in inflammatory myopathy, that you get the patient to specify something that really matters to them in their activity, that's either compromised or verging on being compromised, and then that becomes the primary endpoint for that patient with the impact of rehab. I think it's probably not a good idea to include the minority of patients who are quite clear that they don't like exercise, and some of us do exist. Whenever we feel the urge to exercise, we try to lie down until it is past. And a patient who doesn't value exercise and is probably not a good patient to include in a rehab trial. And then the other point that really strikes me, and I know it's resource limited, and I just don't see this discussed. We use a therapy. We have induction therapy. We have maintenance therapy. We don't induce an effect and stop treatment. Now, in rehab trials, the benefit wears off at 6 to 12 months, but there's no follow-up rehab. There's nothing to do that is done in a trialed way to maintain a benefit. Does that strike you as logical or what? Anyway, I just leave rehab with that thought. Very briefly, ambulatory oxygen. For resting hypoxia, as is entirely appropriate, we depend upon COPD data, and of course if your oxygen's very low, that's a bad thing in terms of survival, and supplementary oxygen both improves quality of life and survival, and actually requiring a controlled trial to approve it is like requiring a controlled trial of whether you should use a parachute when you jump out of an aeroplane. You get a very quick answer, I think. Ambulatory oxygen, more difficult. There's conflicting data, but the major benefit 5 years ago from the AMBOX study is that in a randomized crossover trial, there were unequivocal benefits on quality of life, but a third of patients at the end of the trial said, don't want this anymore, and they stopped it. So I think what happened there is the patients with real benefit wanted to go on, and the patients who didn't like dragging oxygen cylinders around and decided their quality of life was reduced, said they'd stop. And I think this gives us a nice model. We shouldn't be telling people they have to use ambulatory oxygen. There's no evidence ambulatory oxygen improves survival. The patient is the best judge of quality of life. They should judge. the net benefit of quality of life and actually make a decision. But you should find out whether ambulatory oxygen improves 6-minute walk distance or reduces desaturation right at the start, or you're probably wasting your time. Very little new to report with dyspnea and cough, and in the interests of time, which I fear is ticking away, I think I've got about 2 minutes. I must really say something about palliative care. Now, I think when you speak to palliative care, and this bothers me, in different countries that means different things, and in some countries, palliative care is a term that has huge negative connotations. That's the first thing. When I talk to somebody about palliative care, I very, very, very carefully prepare the ground because there's been a change. This is not about the last weeks of life, and I was part of this initiative, which argued for early access to experts in quality of life, which is now how we're talking about palliative care teams. They're there, they're local, they deal with symptoms in a way you can't at a distance. They're experts in planning ahead, understanding patient wishes, and removing anxiety. And so, without going over this in detail, here are 2 statements, one 7 years ago, one last year, which I think are very good reads about the role of palliative care. Now, what really drove this move in patients who've been diagnosed with IPF to actually bring up palliative care at the first or second visit? And I can't do it at the first visit, I will say that much to you. I think that's too much for the patient. But what drove this? First of all, data in Canada, where you've got a lot of support that IPF patients were much less likely to receive palliative care if you don't have a multidisciplinary approach to management at the outset. Then a study I was involved with where there were in-depth interviews with IPF patients, and some of our lab staff were moved to tears by this, where patients described in a matter-of-fact and stoic way their fear of suffocating to death at the last stage of the disease, something that they carried with them for years. And then again, on average, you can document major loss of quality of life where experts in quality of life should be involved 2 years before death. This is my personal algorithm. First of all, explain the diagnosis and actually find out what the patient wishes to discuss. This ghastly tick box where you must force information on patients, I do not like. Find out what the patient knows, and you start with optimism because it's earlier in disease, and we have open label treatment data. It's certainly selective, but there's a sporting chance of little progression in the next 4 to 5 years if you have a better than average benefit with antifibrotic drugs. But you explain the unpredictability and the possibility that you might be unlucky. And you're putting it like that in an optimistic way. And then you're really saying, look, would you like to discuss what might happen if you're unlucky? We don't have to talk about this, but you might find it helpful to know there's a way ahead. You might find your wife, your partner, your husband also really values that. What would you like to talk about? And that way you're being invited to express this, and then you can go into all of the benefits that can arise if you've got a really supportive quality of life specialist who can talk about the present and the future. So for very early referral, you're avoiding lack of support in later disease. The right patients and caregivers can benefit greatly with better planning and a reduction in anxiety due to uncertainty. The cons, time is required to do this sensitively in a busy practice Don't try doing it the same day you're telling somebody they've got an IPF diagnosis. Give them the diagnosis and the next sentence is about palliative care. No, I think that's a little bit compressed. And cultural issues, I come back. In some countries, it really isn't acceptable to be talking about management that actually accepts there are things you can't do. And in the Middle East especially, in some countries, you simply cannot do that. So that's the end of my talk. I've tried to keep to therapies you can use. I've touched on the problem in IPF, but not gone into detail on drugs you can't yet use, but highlighted our problem that some of the more recent drugs are selective, but probably in their pathways they're selective and they apply only to a minority of patients, and we haven't got a model to deal with this. And finally, I've covered standard symptomatic approaches. My apologies for some missed slides. I've no idea what happened to the font, but I think at least I've saved you from trying to decipher these in my talk. Thank you very much.
Professor Atalwal, I think thank you very much for giving very important information regarding the current evidence in the management of interstitial lung disease as well as the symptom-based management. I think it's a very difficult task, and as a practicing clinicians, we have several doubts in management of interstitial and the ever-changing pattern over the 25 years. We as a practicing clinician, now the various evidence are coming and then we are rejecting and then the new everything. And in the practicing clinician, we feel that how difficult to manage the interstitial lung disease, particularly IPF and its secondary ILD, CTD, and the current evidence are daily changing, and you updated all of us, all what is the new in today and in the current literature in the world regarding the management that both of us will discuss. Allow one or two questions because it's a rare opportunity to have Professor Wolf here. So Wolf here in this forum. One or two questions we can allow introduce yourself and it will be very brief questions.
So I'm Bhavin Jankaria, I'm a radiologist. But my question is, do we have long-term data from InBuild that perhaps shows us what happens to the cohorts 5 years down the line? And does it make a difference over a period of time? Does nintedanib really work long-term?
I think we have to wait a bit longer for that, but all of the evidence we have, which is based more on IPF than it is on PPF, but bear in mind the effect is supernaturally similar, and on average in InBuild 60% of progression prevented, in IPF studies 50%. And we don't yet have the sort of 5 to 6 year follow-up in InBuild, but I would remind you open label trials are, you've got to interpret them very carefully. And what you can say about both drugs, pirfenidone and nintedanib, about IPF, and I believe strongly we will see the same with PPF, there's no reason to imagine otherwise, is that first of all, half of patients withdraw from these studies and they don't get followed. And I think their outcomes will be bad. Now, if you take that into account, the open label trials don't give you a whole cohort benefit that is magnificent, despite the way in which the two studies were presented by the writing groups that present them. They talk about a whole cohort effect. This is a half cohort that remain under follow-up and go on taking the drug. And if you're in that half cohort, you have very little progression over 5 years. So what that is telling us is that both of the drugs give us about half of patients doing extremely well over 5 years, and probably the other half having the same bad outcome as in IPF and the PPF equivalent UIP patterns, the same bad outcome as before. We never had half of patients doing well that were behaving like IPF or who had IPF. I believe that's what we'll see with the open label. There will be a subgroup that withdraw from open label that we'll never get to hear about, and those that remain on active treatment, I'm predicting will be like IPF, that those who continue on active treatment are continuing because the drugs they believe are working, and they will do well. But this is speculation. When you have no data, you've got to speculate. Yes. No, but you can make a reasonable estimate because the analogy with IPF is so sharp.
I'm a consultant respiratory physician. Thank you very much, Professor Wells, for that wonderful lecture. Now, given the new data about rituximab in systemic sclerosis, ILD, don't you think as an induction, what are your thoughts about induction of systemic sclerosis, ILD with rituximab on top of MMF?
It's the second question in a row that is a very good question on which there are simply no data. So if you're asking me about induction, I would draw a distinction between those patients in whom you want a more rapid treatment effect because they're either very progressive or severe, and the majority of patients in which you actually don't necessarily want that. And just as using nintedanib, I would say that if you've got severe scleroderma lung at presentation, why would you not use a combination of mycophenolate and nintedanib? Because any further progression will disable the patient if they're severe to begin with. I'd make the same sort of observation about other combinations. So I would not use rituximab and mycophenolate across the whole spectrum of scleroderma lung for induction. I've seen too often that these induction approaches will have some downsides. Rituximab can cause permanent hypogammaglobulinemia. So I would say that unless you have severe disease, and I'd use the scleroderma CT FVC staging system, if you have limited disease, I'd be keener on avoiding adverse effects, using mycophenolate because that's good for systemic disease generally anyway, and then making a judgment with time. And if there's severe disease, I think it's different. And especially that disease where within a year of first symptom, you have extensive lung disease. I think you view that as something of an emergency, and combinations become appropriate. Now, personally, I'd use mycophenolate and nintedanib rather than mycophenolate and rituximab, but I could see how somebody might argue either way.
Yeah, once again, thank you very much, Professor Wells. We have Sri Lanka College of Pulmonologists. You may have many queries you may discuss with Professor Wells during your tea times, and that even today and tomorrow. I'm closing this session. Thank you very much, all of you, to be here presenting at the first guest lecture.
Thank you, sir, for that informative lecture. Now I cordially invite the chairpersons to present the token of appreciation to our speaker, Professor Athol Wells. Thank you, sir. Next, I invite Dr. Saman Kularatna, Consultant Respiratory Physician, to present the tokens of appreciation for the chairpersons.